Good morning from New York.
Hi,
Can you
good
hear
morning.
us?
Yes, we can hear you very well. Great. Hi, this is Samir Kapadia, and we are here with a very esteemed panel, and we are waiting for your case to see what you're going to present, Dr. Kinney. And maybe you
Okay.
can introduce your team and introduce the patient.
Thank you for the invitation, Samir. Myself, Dr. Kinney, I'm the director of the Cath Lab here. I have Sahil Kera, who is the director of the structural heart for Mount Sinai. Dr. Lirakas, who will be at the echo. And then we have Dr. Itagaki, who is going to be the surgeon along with us. I have two fellows, Richard Supawat, and anesthesia is Dr. Minakam Wiener. So we'll start presenting our case. And we have
Show the first slide,
first
please.
slide. We will have Dr. Tang, who actually is online joining us.
Yes, he's
So,
with us already.
okay, good. So if you can see the slide, the 80-year-old female who actually presented with dyspnea and exertion. This patient has been a patient of Sahil Kera for many years. He has been following her after having done the tower. So if you see there, that she has been having dyspnea and more important also change in the EF over the years. So past medical history of hypertension, hyperlipidemia, EF has been around 30 even before, history of CVA in the past, no residual. So she did have tower with the 29 Evolute Pro way back in 2021 at an outside hospital, but after that developed cancer and has had a major treatment. If you see that radiation as well as chemotherapy, and was supposed to had colostomy, and now supposed to go through reversal of colostomy. That's when I think we also realized that her symptoms are getting worse and not ready for clearance. So medications, she has been on a good medical therapy for her heart failure, which includes Entresto, spironolactone, carvedilol. Labs are okay. So we can show you I'm going to show the echo here, but more important, I think you can show the live echo.
Yes, yes, Dr. Kenny, thank you. Good morning.
Can we go to the live echo? Yes.
It's showing, yes. So you can see this four sample review, mid-esophageal, LV, as you can see, severely dilated, severely depressed LV function, estimated ejection fraction about 20-25%. The right ventricle is also mild dilated with mild decreased function. No much mitral regurgitation. And here is you can appreciate the paravalvular leak, posterior PVL. As you can see here, the vena contracta is 0.5, which is consistent with moderate PVL here, but we have, of course, many measurements, as you can see. This is a short axis view, and you can see the PVL up in around 11 o'clock, posterior PVL. And one of the ways to measure this is to measure the circumference of the PVL compared to the circumference of the frame of the valve. And as you can see here is 40%, which is consistent with severe paravalvular regurgitation. You can appreciate here the gastric images, severely dilated left ventricle with severe depressed function, as you can see here. And this is a deep gastric view of the valve, as you can see here. And this with X-plane, you can see minimal central aortic regurgitation with mostly significant paravalvular regurgitation. The leaflets open well, the mean gradient is 9. And this is another view to appreciate the paravalvular regurgitation. And the pressure half time we get here is 150, consistent with severe paravalvular regurgitation, as you can see also of the density of the PVL. And this is the aorta with a lot of grade 5 atheromas. Thank you very much.
Okay, now let's go back to the slides. So this is, we already seen the echo. This is the CT scan before the first tower. So,
Yeah.
Sahil, yeah.
So, hi, good morning, everyone in Riyadh. Thank you for having us. So, very challenging case who I've known for some time now. Patient had a TAVI done outside, And if you pay attention clearly to the non-coronary cusp on the native CT scan, there's a lot of leaflet calcification at the base, and this will help us determine what's happening right now. So can we see the next slide, please? And you can see it here, very calcified base of the leaflet on the non. It was an appropriate case for a 29 core valve back in the day. Next slide. And you can see that ascending aorta, aortic valve are pretty calcified. Next slide, please. And this is the issue. So the issue is that you have a very underexpanded 29 valve. Your perimeters around 66 to 64 all throughout from node 3 node to node 6. And probably because of that very bulky calcification on the non-coronary leaflet that has prevented any expansion of this valve. And this patient has had a drop in EF. We managed for heart failure. We put a CRT, but she's still very symptomatic. And we said, you know what? There is an underexpanded valve. It doesn't have a lot of recoil because of that calcium sitting outside. It'll be best suited for a TAV and TAV. Next slide, please. And you can see it here again, severely underexpanded. And we did a virtual simulation of a 23 inside. And your coronary heights are pretty generous. Left coronary around 13, right around 13.9. Next slide.
So I think an important point when we are doing TAV in TAV, the biggest, I think Samir can also add to this, is always the coronary obstruction. This is a very important point that we need to watch for, look for this. So here you see that the height for left and right are excellent. So we should not have any issue when we place the second valve.
And the access, all redo TAVRs, for some reason, they have challenging accesses. This patient has an infrarenal aneurysm with some thrombus there. You can see the mural thrombus. There is calcification in the common iliac. The vessel size is around 5.1 in the minimal diameter. There's a chunk of calcium and more than 270 arc. So the plan here was to do IVL of that area, sort of open it up, make it more compliant, and then put our E-sheath through it. And we balloon dilate our E-sheath because I'm going to show you, we've had experiences when you have calcified tortuous anatomy, when the sapien valve is going through an unexpanded E-sheath, the stent frame can actually abut out and get engaged into the calcium, causing iliac injury. So we routinely do balloon dilatation of these E-sheaths once they're in situ, so it helps in good traction of the valve. Anyone wants to comment on that? Samir, maybe you can. Yeah.
No, just I wanted to ask the panel and you first that the valve is functioning well. So when do you consider to post-dilate this valve, and when do you consider to do a paravalvular leak closure with a device before you put a new valve inside? So this is, would you consider, did they post-dilate before?
Yeah, no, that's a very good point. And we have learned from experience that once you have this thick chunk of calcium sitting outside, even though you post-dilate, you end up having a recoil in these cases. Secondary, doing a PVL closure through these tall frame core valves is extremely challenging. And what happens is you have leaflet impingement. So it's a very tricky situation. And I feel that TAV and TAV in these kind of underexpanded valves with a big chunk of calcium outside is more reasonable, especially when patient has had a drop in EF and is very symptomatic.
Other question also is the original implant has been low.
Yes.
So that could be the reason also that that probably did not seal well. Gilbert, do you want to add anything to Samir's question?
No,
we had
one case before, Gilbert, just if you don't mind. We had one case before, like 8 months after the deployment of the first generation TAVI. He had a very progressive aortic regurgitation. There was a chunk of calcium. And we did the ballooning, and actually we had more transvalvular regurg, and we could not improve that paravalvular leak or the calcium. Then we ended by giving the case to our surgeon, actually. Go ahead, Gilbert.
Yeah, no, that's an excellent point. And Samir's question. So if you post-dilate a tall self-expanding valve too aggressively with especially non-compliant balloon, you can tear the leaflet. That's why Medtronic has a new IFU on how big a true or non-compliant balloon you can do. Remember, all these Evolut platform core valve had a waist. So in this case, with 29 Evolut, the waist is only 23. So you can technically go up to a 24 true. Anything bigger, it's going to tear the leaflet. And we had a case actually referred to us because of that. The outside
But
hospital did
even
not know.
even 23 millimeter balloon, I think you could try to just post dilate it to see
Right.
if one of the
But
options.
as you
But
know,
of course,
Samir, this valve was implanted deep, and the analyst is well more than 23, so it's
Mhm.
not going to really touch the frame, and that's been our experience. We try to post dilate first when we can, but we have not been successful. So rather than doing that, as long as the tab is safe, and this patient obviously is not a TAVR explant candidate, she's extreme risk, we think that we should just do that with a higher radial force to be able to take care of these problems potentially.
Can
See,
we
other
listen to the opinion of our surgeon? Can you just for a second? Our surgeon, I need his comment. The surgeon here. اللي في النص يا أحمد.
just touch it. Yeah.
Yes.
Thank you very much. I think the question I would like to ask here is that if this patient is not going for any other procedure, would you have tackled this BBL? Because I assume it's been there since the procedure.
Right. So I would have tackled this PBL, and I'll tell you why. So this patient did fairly well for almost a year. I think it was mild to moderate to begin with, and this patient had progressive dilatation of the LV cavity. The EF had dropped from 45% to 27%. Patient was in profound heart failure, for the most part NYHA class 3, on GDMT. Then we went ahead and did a CRT implantation, no change in symptoms. So I think I would have still done it.
That's great. Let us go ahead and do the procedure because everybody's waiting to see how you do it. So
So this is, I think we did a angiogram again to check the coronaries, which are okay. You see here.
yeah.
So let's quickly talk about the sizing here. We want to deploy at node 6, and you can see now the TAV app made by Vinny and Fukui. You can basically measure down your nodes to get a true size. You average that out. Next slide, please. And as your step 2, you identify your coronary risk plane, and your coronary risk plane is basically below the lowest coronary ostia. So in this case, it's node 6. Next slide, please. And we are pretty confident. Next slide. We are pretty confident that the coronary risk plane is low. The neoskirt plane is going to be low if we deploy at node 6, and that'll be a good sort of starting point for this case. Next slide. And this is why we are not using 26. So if you used to look at the old apps, it would suggest using a 26 inside a 29 evolute, but those are high risk of ruptures. 23 should help you for the most part if you have PVL and an underexpanded frame. If it was purely degeneration and the patient was not very big or BSA wasn't high, then 20 is also reasonable. So the key is you average out all the numbers and you go 1 or 2 size smaller than the in vitro sizing, and that almost always helps you. So 23, in my opinion, is most appropriate. Maybe we'll add 1 more cc to it during the post-dilatation.
What was the pre-TAVR annular area?
Yeah, pre-TAVR, the perimeter was around 76 and the average was around 24.
Yeah.
Okay, we can go on fluoro.
Let's go live, please.
Yeah, live. And let's have the hemo by the side by side.
Valve is crimped.
So crossing should be use a pigtail. Yes, many times it can go by itself. Yeah, like it did now. Should be easy. Yes. And let's just show some hemos.
Any questions from the audience in the meantime?
No, we just wanted to know that did you have to do anything to the groin, because I see that you already have a sheath.
I
in
did.
place,
Yeah,
so-
I did IVL and balloon the E sheath.
Okay.
Can we show the images quickly? And we also have a sentinel. So this is IVL. You can see the first image here. So that's where that lesion was. Did a nice IVL with a 7.0 balloon. Got our E sheath in and
Okay.
ballooned the E sheath. All right.
Okay, so you saw the way we crossed, and we'll just go directly with the wire. We have the valve ready. So as the discussion happened, I think we will just go directly with the valve.
I will ask Samir here. Do you take care of those axes in the redo TAVI, do you think they become more calcified, or because we are using the closure device, the anatomy is different?
No, I think it is just the older age of the patient
Yeah.
that
Well,
makes it like that, but it's not the perclose or anything like
Yeah.
that.
Yeah.
And if they could do it before, I guess this is how I look at it, to say that if somebody could do it one time, it's very likely that we can go through the groin
Yeah, exactly.
again. Yeah. So the one question is that you have a pacemaker, just for fun, that you have a pacemaker, but you still put another temporary wire. Huh? You don't use the box
we
to
usually don't.
pace?
No. This is, I think, just
Because it
keeps the
is
cadence
very,
of the room and keeps the room moving faster. Um, that's a good point. Used to back in the day, during Gilbert remembers this when I was a fellow with him,
Give me dry gauze.
but not anymore.
Yeah, and Samir, we found that sometimes if we go for the same groin for the
Dry.
redo tower, it's a little bit more scar. And a couple of times we actually had trouble deploying the the E sheath, and it got stuck at the groin. We had to end up doing a little
Sure.
bit more extended incision
Wire.
and dissect down to the artery to actually deploy the perclose as well.
Pull back.
Keep going a little.
Pull
Pull the
the
sheet
wire
back. Pull the sheet back. Good. Pull the sheet back.
Yes.
They will find out later.
Push the wire. Yeah. Good. Okay.
Let the advance the wire. Okay, ready?
Yeah. Let's go.
Okay. Go.
Go. Show me
We
out.
have the sentinel.
Yeah.
1 second.
Arch.
Careful now when we are entering here.
Keep going. Going.
Full.
Keep going. Good.
Okay. Hold the wire.
I'm sure Dr. Kapadia is very happy with the sentinel here.
I know. Thank you
No, hold
for
on.
putting it. The only
Pigtail.
question I had in my
Where's the
mind was that
pigtail?
this is not a
We need a
calcified
pigtail.
valve, so you're putting it because of the aortic atheroma, right? That's what.
That is correct. That is absolutely correct. Very porcelain aorta.
Right. Porcelain aorta. That's why you're putting it. Yeah. Because I was thinking in my mind that whether this needs it or not, but I saw on the echo,
We can have some
STEM showed us.
Go ahead. You
Yes,
wanna see
Actually,
this?
this is the second case today with the Sentinel, which is
So
good.
Get the
So
pigtail.
what are you trying to do now?
Get the pigtail.
No, I think we need the
So,
pigtail.
yeah.
Just okay.
So you
wire,
can see
wire,
there's
wire,
an
wire.
aneurysm there. Go ahead. Good. All right.
But we don't need a injection, right? Do you?
No, towards the end we'll just do
No,
it.
I
She
think
just
we may
likes to
need
keep it
I
there.
like to keep the
Yeah.
only normally would not, but here I know we are discussing node 6, node 5. I think I just want to be sure. Yeah, I'm still a believer of our original. Go with the original annulus.
One thing about AK is she always sticks to her principles.
Yeah.
Never changes.
And I agree with Dr. Kinney here. You
I think
definitely want to
the wrist
visualize
valve
the
is down
left main takeoff here
Yes.
to be
little
sure.
bit deep.
You
Yeah.
Always
Let
be
me
just
see.
safe.
leave it there.
And,
Yeah.
that's been our
Yes.
principle.
Okay, that's
here.
good. Okay, ready?
Okay.
Okay, now show me some die. Who has it? Good. Yeah.
So you can
what do
see
you
it here.
think?
Let's do a
I'm
cine,
going to
180 cine.
pull
Yeah,
back a
that's
little
good.
bit this way.
Pace
Okay.
180.
180.
Cine.
Who is pacing? Good.
Cine.
Inject.
Off. So we are
There's a
at
PVC.
node 7 here.
What do you think, Gilbert?
But I think
Yeah, I think you can start at node 7 and slow inflation. We've had experience where these valves, because of low oversized the balloon, there's a little watermelon seating. So the concern is that if you start at node 6, you might end up deeper. We had one case that we
Yes.
performed live that happened.
Yeah, I agree.
So but also at the same time, it can go up. So you just have to go very slow inflation. And the other comment I have is that if this is an acute case, then you have to rescue, and there's not much calcium on the valve, you have to be careful that when you cross the sapien 3 in the evolute can move. But obviously not in this case.
Yeah.
But for the audience, just keep that in mind. If you have to rescue, be very careful cross because the frame to frame interaction. But I think it looks good. You just go slow
Yeah.
Okay.
inflation and
Go 180.
and move.
So we're going to go inflate inflation, Minakam. EF is low, so okay, go. Okay, go full. Complete. You can see that thick calcium. Yeah, I think I have to do one more inflation.
Keep pacing. Off. Add 1 cc. Give me 1 more cc. Good.
Can you show us the TE?
Yeah, TE
Yes,
quickly.
stay on.
Yeah, it's everything is. I think it's better now.
Yes.
Yeah.
Want to go 1 more cc, please. I want to do 1 more
Let's
inflation.
ask
It's about,
Samir and the panel.
Little
I
bit
think we
decrease,
go.
but
Yeah, but let us see
yeah.
we don't see the TE, but I think it looks
Can
good.
we show
Yeah.
this? Yeah.
Oh, yeah, you still have a little bit of.
Okay, we're just going to go 1 more cc. Gentle inflation.
Yeah,
Okay,
I think.
Yes.
Yeah.
Everybody
That's good.
agrees? Okay, we'll go.
Yeah.
Yep. Yes.
Okay.
Okay. Pace 180.
Okay, go. Full. You have to wait.
Yeah, with the inflation, it's better. Yeah.
Okay.
Okay, off.
Yeah, much better.
Look at that, sir.
Okay.
So
let's
Yeah.
have
It's
the,
just-
okay, come out.
Start the frame
do
out.
you use TE routinely in TAV?
I personally don't, but in this patient, I think because they're treating it for paravalvular leak, it might be a good idea to be 100% sure.
Yep.
It still has some leak left, but
I
Mild,
think even
definitely-
us, we don't use it.
we're small, much less. Yeah.
Yeah,
It is
definitely.
less than before.
Yeah, definitely better.
And the
From
diastolic
severe-
has
From
improved.
severe
up,
to
yeah.
mild.
Okay, come out.
Let's zero everything here quickly.
Now come out here. Let's put a pigtail and take it
Show
out.
me chloro.
That's good.
It does. It's gonna be
Careful,
any better
careful.
Yeah.
because at the time of inflation, you can see it's actually sealed, but
Yeah.
then at the moment the balloon is down, it's recoiled. So
Yes.
I believe it's gonna be like this, no matter how much they put more.
Yeah, also
Yeah,
this
no, that's a
document-
great observation.
Go ahead, please, yeah.
I think we have to appreciate that the cause for the leak is that because the valve was low sighted.
yes.
And whatever you do at the level of the
Some color there,
annulus
please. Yeah, some color.
is not going to secure the leak. So I think this is the best result they would achieve.
Give the pigtail.
Yeah, and,
Other option is to just put a
gradient, please.
closer plug.
Yeah, you're absolutely right. The panelist is very astute to observe that. When you have a deep implant, remember the native annulus is larger than 23. So we're just trying to expand using balloon expandable valve to increase the radial force and expansion against the native anatomy. You still have an annular calcium there, as you saw in the pre-TAVR CT. That's why we like to get the pre-TAVR CT when possible, because it tells the native anatomy. There have been cases of annular rupture with TAV in TAV, so that's important to know from oversizing. And in this particular case, I think the deep implant will show the aortogram shortly. It's extremely, it's a perfect spot, and you would definitely post dilate for 2 reasons. One, to expand the first valve to be able to get less recoil, and 2, that's been a description of called frame-to-frame leak, a peri-frame leak. So if you don't oppose the 2 frames properly, you have a leak between the frames. So that actually minimizes the possibility of that as well. So we're going to do a post CT on this patient, probably at 30-day follow-up, just to
Off color.
Zero. Yeah, that's a very good point, Gilbert. Transvalvular leak is something we don't discuss much often, and you really want that, a trans between the 2 valves.
Some color.
And that's why I think post-dilatation is so important in these cases.
There's a little bit of a mitral flow you see, right? There.
Yeah,
So that's why it looks little.
Yeah, this mitral inflow, the PVL is definitely much better. It's mild, as you can see here. Yeah, okay, take that. Mean gradient of 3.
Looks good.
Here's the depth.
Yeah, I think it looks good,
Can
and
I
the result is.
aortogram as well, Sahil?
What?
No, I
Sorry.
think it looks excellent.
Sorry.
Aortogram?
No, I
yes.
didn't. You want me to? We can do one. You want one?
Yeah, we should definitely do. I think that's one of the things, just to confirm what I think you guys nailed it. Congratulations. That's not easy, by the way. We've done the most TAV in TAV cases live in the
Give me a while.
world, probably, over the last 2 years. And we're still learning. And with the collaboration with Mini Bapat and Miho at Minneapolis Heart, we now trying to validate their app, which will launch shortly, to look at these and understand this, so that anyone in the world can do this safely and reproduce it.
Yes.
Yeah, I think that's a very
While you
good
do
point.
the aerogram, let me ask the panel that I know that when you are, the sizing of the TAV in TAV is a tricky one.
T up.
So,
Sorry. Yeah.
so the question is that there are two,
It's
three
okay.
ways of doing it. But one of the ways, of course, is to say that what was the original annulus. So in this 29 millimeter
Ready?
evolute, one option is to put a 26 or one option is to put a 23 because both are options.
ready?
And if the initial annulus could tolerate,
Beautiful.
yeah, it's much better. It's still there, but much better. So the question is that how do you guys do it? If you had to do TAV in TAV, one of the panel members,
Actually, I was wondering whether coiling the paravalvular leak would have a role in this case before considering a valve in valve, or even after.
Show me.
like a plug.
Yes.
Yeah, I think vascular plug 2 is my favorite plug for these purposes. And usually, I know that sometimes it can be tricky with the core valve, with the self-expanding valve. But in this situation where you have a sinus that is large, you don't have to protrude the proximal disc inside of the valve. So it will not pin the valve. You can put it all outside in the sinus. If the sinus is not there, then you are kind of stuck. Then it is, as they're mentioning, it is a little bit trickier to close. But this particular one, there is a possibility because it's in the posterior sinus, in the posterior commissure. It is technically a little bit easier than otherwise.
Kenny, you are ready with your slides?
Yes, I have some slides which we
Go ahead.
had decided.
Oh, sure.
Yeah,
Yeah,
this is
just
our plan.
yes.
Go ahead.
This
Go
is
ahead,
what.
yeah, please.
Yeah, tower or sour degeneration. What is should be done? Valve in valve tower. For that we do TAV in TAV or tower explant. So I think the most important slide would be this one for us to go over. So this was just came out in 22. What should be the therapeutic option? So what they call is BVD, bioprosthetic aortic valve dysfunction. So that they divide into two. Is it structural valve dysfunction or a non-structural valve dysfunction? So if it is a structural valve dysfunction, which was not the case here, in our case were important factors to be concerned to decide should the patient go for another surgery versus should be a tower. So important, which we discussed earlier also, is a coronary flow. Would there be coronary flow obstruction when we place this when we place a tower? What about the access for the coronary after the tower? And other thing is residual, patient prosthesis mismatch. If you don't have that, we can consider a redo tower, or we should then consider patient should go for a SAVR. Now, our case here is a non-structural valve degeneration, which was severe PVL. And then we decide, can a redo tower be done? Here we knew, based on all the discussion we had, a redo tower was feasible. That's why we decided on doing a redo tower. If the patient had a acceptable surgical risk and tower was not an option there, then you consider a tower in that case. Now, if there is a severe patient prosthesis mismatch, the first question we ask is, can we dilate it? Can we do the frame fracture? So if that is doable, which we have shown in a couple of cases, that you do a balloon fracture the frame and then do the TAVR. If that is not doable, depending on what kind of a previous surgical valve or whatever it is, you have to consider a redo surgery. And of course, if there is a valve thrombosis, endocarditis, there is no question, patient should definitely go for surgery. TAVR is not an option in this case. And I think a little bit of this discussion happened. And I think for us as interventionalists, first and foremost, we have to start thinking is, how do you treat patients with aortic stenosis? You have to think of the lifelong management, that even when you place your first TAVR, now you have to think that if the patient is coming for a second TAVR, the first TAVR placement has to be perfect, so that when they're coming for the second TAVR, that there is no various issues that we have discussed. So the things that you need to take into consideration would be based on the CT scan, the root anatomy, coronary obstruction risk, which is based on the design, the depth. Here we knew that the depth of this TAVR valve was lower, commissural alignment, and what is the kind of valve we are going to use when they come back, whether it is going to be balloon expandable versus a self-expandable valve. So all these things need to be taken into consideration even when we do first. Couple of papers that we are going to go over is a recent publication that came out in the Lancet, the outcome of redo TAVR versus native TAVR, that both have similar outcomes. So redo TAVR is feasible, though if you see here is a big number, 1300 in each cases there. So that is doable. So where we have to rethink how to take care of this patient, whether it is TAV in TAV or TAVR explant, something that we got to consider in this patient. So if you see there, if you 30-day procedural outcome up to 66% mortality in these patients. So repeat TAVR 6.2 and TAVR explant is 12%. And this is, I think, the number that you see in various publications that have come out, that TAVR explant is not an easy surgery, that there is mortality associated for in-hospital 30-day as well as 1 year. But for certain group of patient, repeat TAVR can be performed with this 30-day mortality that is accepted. Now, this is the paper which was published from the group and Gilbert was the senior author. I'm going to show first and then ask Gilbert for his comment, where what they did was explant versus surgery. Patients who had endocarditis were completely excluded. Then they took 396 patients, redo TAVR versus explant, about 200 versus 181, and see what they found. Very important, if you focus on the mortality, which is on the right top corner, that redo TAVR has a lower in hospital 30-day and 1 year. But if they had gone for surgery, look at their almost 13% at 30 days, and 1 year goes really high up to 30%. So explant surgery is not something that is benign. And Gilbert, anything else you want to add on this paper?
Yeah, no, I think what we learned is that if you saw the table on the left, if you have severe PPM, you really don't have much options for redo TAVR. You pretty much have the surgery and enlarged aortic root. That's really the key message for this paper. So the point is that avoid severe PPM when you start up with your first TAVR. And then the other point is that these are obviously carefully selected patients, but those who survive at 1 year, there were no mortality difference. So if you survive the initial surgery, you'll do okay, just like the redo TAVR. So I think the key is that surgeons are getting better and outcomes are getting better at doing TAVR explant, but these patients should still be referred to experienced centers because they are more complex surgeries. And I'd be happy to hear what the surgeons on the panel can comment on this as well.
I have a couple more slides, and this is another one where we are comparing. This is an important point. Other one is TAV in TAV versus TAV in surgical valve. So if you see here, very important that if you did a TAVR in TAVR versus TAVR in a surgical valve, go back to the leftmost, that there is a residual gradient. Here we saw that there was no residual gradient. 20% of the time, there is a gradient more than 20 millimeters of mercury left when you do TAV in TAV. Something for us to be noting and look at the procedural success as well as safety for TAV in SAV and TAV in TAV. It's just about 70% or so, something that for us to note that.
We have to end the live transmission because we have a ceremony. I would like to thank you from Mount Sinai, you, Samir Sharma, Gilbert Tang, all the team for successful case and presentation. Thank you very much.